The term non-alcoholic fatty liver disease was coined in the 1980s. It is currently the most common cause of chronic liver disease. Non-alcoholic fatty liver disease will be abbreviated as NAFLD, and for the sake of this presentation, I'm going to elude it as NAFL. It is defined as hepatic steatosis in the absence of a secondary cause. Secondary causes of fatty liver disease include alcohol, medication or drugs, or any form of viral hepatitis, autoimmune disorder, or metabolic disorder. NAFL is a spectrum of disease from steatosis, that's fatty liver, to non-alcoholic steatohepatitis, non-alcoholic steatofibrosis, cirrhosis, and complications of cirrhosis. The clinical pathophysiological entity resembles alcohol-induced liver injury in patients with no or minimal history of alcohol consumption. Both alcoholic fatty liver disease and NAFL can lead to necroinflammation, progressive fibrosis, and cirrhosis of the liver, and also complications of cirrhosis. Complication of liver cirrhosis includes vomiting blood, and this is due to variceal bleed, accumulation of water in the abdominal cavity called ascites, infection of the abdominal cavity called spontaneous bacterial peritonitis, confusional state in patient with liver disease, and this is termed as hepatic encephalopathy, progressive liver failure, and this leads on to jaundice or yellowness of the eye, and of course the dreaded liver cancer or hepatocellular carcinoma. NAFL is a leading cause of cryptogenic liver cirrhosis. Up to about 70% of diabetics have fatty liver disease. Up to about 80% of obese patients have fatty liver disease. NAFL is the hepatic manifestation of cardiometabolic syndrome linked to insulin resistance. NAFL has cardiac-related events, morbidity, and mortality. The commonest cause of death with NAFL and NASH is cardiovascular disease. The term metabolic dysfunction associated with fatty liver disease, or abbreviated MAFLD, was coined 2020. Is the detection of fatty liver by histology, imaging, or blood biomarkers, in addition to one of the three criteria: patient being overweight or obesity, presence of type 2 diabetes mellitus, or metabolic dysfunction. NAFL can take two causes. One is liver-related morbidity and mortality. The other is cardiovascular-related morbidity and mortality. Fortunately, more than 80% of NAFL will remain as a benign condition, has an isolated fatty liver with none or minimal risk of death due to cardiovascular disease, or none or minimal progression to cirrhosis or cirrhosis-related morbidity and mortality. The prevalence of NAFL is about 10 to 24% worldwide. NASH is about 2 to 3%. NASH is a precursor to complications of liver disease. The prevalence is 2 times higher in males. The prevalence of NAFL has been increasing with time. Most patients are diagnosed with NAFL in their 40s and 50s. The detection enables us to retard and halt the progression of NAFL. The pathophysiology of NAFL is complex and not fully elucidated. The most widely accepted theory will be the double hit concept or theory, which involves the pre-existing insulin resistance in patients with NAFL. The second hit is most likely due to poor lifestyle or poor diet, namely metabolic dysfunction. Most patients with NAFL are usually asymptomatic. NAFL is usually diagnosed during a medical checkup or health screening, which includes an ultrasound of the abdomen. Otherwise, it's an incidental finding when an ultrasound is performed for some other reason. One of the commonest symptoms of NAFL is fatigue or tiredness. Clinical examinations of patients with NAFL is essentially normal. There can be stigmata or chronic liver disease, example, a liver palm, or hepatomegaly, a soft palpable liver. In advanced cases of NAFL, they can present with features of cirrhosis and complications of cirrhosis. NAFL is associated with metabolic syndrome, obesity, type 2 diabetes mellitus, dyslipidemia, hypothyroidism, polycystic ovarian syndrome, obstructive sleep apnea, hyperuricemia, and cardiovascular disease. Liver function test is essentially normal in NAFL. There can be mild elevations of liver enzymes or transaminases, and this is typically seen in non-alcoholic steatohepatitis. That's the stage where it's progression into complications of liver disease. There can be an elevated fasting glucose, triglycerides, and low HDL with insulin resistance. Importantly, normal blood test does not rule out NAFL. In patients with fatty liver, the level of transaminases does not predict liver injury or levels of fibrosis. Ultrasound of the liver is a non-invasive test with a very high sensitivity and specificity to detect fatty liver, but it cannot distinguish the stages or the grades of steatohepatitis or fibrosis. Ultrasound helps to exclude other causes, including gallstones. Unfortunately, ultrasound is operator dependent, and if one is not looking for it, one may miss fatty liver. Occasionally, there can be over-reporting too. Ultrasound cannot categorize the stages between fatty liver and cirrhosis. There are serum-based proprietary biomarker panels for the diagnosis of NAFLD and staging of fibrosis, steatosis, necroinflammation in NAFLD patients. They are also useful in the monitoring of the disease. Vibration-controlled transient elastography, we have something called FibroScan in Pantai Hospital, offers liver stiffness measurement and also control attenuation parameters to assess fibrosis and steatosis respectively. This is a very quick test. It takes about 5 to 10 minutes, easy to perform, very short learning curve, and very non-invasive and can be done by the bedside. The staging of steatosis is deemed mild, that is S1, moderate, that's S2, severe, that's S3. It also staged the fibrosis as stage 1, that's F1, F2, F3, and F4. F4 is marked as cirrhosis. Very importantly, early stages of fibrosis is reversible if the underlying disease is diagnosed early and treated. Liver biopsy is the gold standard to obtain histological diagnosis and to assess necroinflammation, steatosis, and fibrosis. Unfortunately, it's invasive, costly, and there may be something called sampling error. The non-invasive tests mentioned earlier, as the vibration-controlled transient elastography and the serum-based biomarker panels, are now the standard of practice. Patients with advanced fibrosis need to be referred to a specialist. Fibrosis is the strongest predictor of liver-related mortality and morbidity in patients with NAFLD. The mainstay of treatment for NAFLD and NASH is lifestyle modification, which includes weight loss. A 5% weight loss reduces steatosis. A 7 to 10% weight loss improves NASH histology. Weight loss retards or stops disease progression. Weight loss can lead to improvement of liver function tests, liver histology scores, serum insulin level, and quality of life.
After diagnosed with non-alcoholic fatty liver disease, the priority should be given to achieving healthy body weight and acceptable body fat. So usually for overweight and obese patients with non-alcoholic fatty liver disease, we will recommend 5 to 10% of weight loss with the rate of 0.5 to 1 kg of weight reduction per week. So in order to lose weight, both dietary control and regular exercise are the two very essential elements in weight reduction. Here are a few tips on how to eat healthily to improve or prevent non-alcoholic fatty liver disease. Tip number 1. For those who are overweight and obese, it is advised to adjust their total calorie intake per day in order to help them achieve that 5 to 10% of weight loss. So we're talking about 500 to 1000 calories per day lesser from their usual calorie intake. We usually help them in achieving that weight loss. So remember not to go for extreme dieting to achieve rapid weight loss, as rapid weight loss can be detrimental and may even worsen non-alcoholic fatty liver disease. Tip number 2. It is advised to cut back on the intake of refined carbohydrates and sugar from any sugary drinks and food, and also to limit the excess consumption of fructose, especially from high fructose corn syrup. So high fructose corn syrup are usually added in processed food, such as cordial drinks, carbonated drinks, breakfast cereals, jams or other bread spreads, sauces, and also confectionaries. So research shows that excessive fructose intake stimulates the production of fatty acids, while inhibit the secretion of satiety hormones, which indirectly leads to more calorie intake. Tip number 3. It is advised to also include high fiber food in your daily diet, such as multigrain rice, wholemeal bread, legumes, fruits, and also vegetables. So this is because diet high in fiber can actually help in maintaining good blood sugar profile and cholesterol profile, especially among patients with non-alcoholic steatohepatitis. Tip number 4, choose the right fats. So limit the intake of saturated fats from meat fats, full cream dairy products, and also limit the intake of trans fat, which is usually from processed meat and hard margarine, while at the same time replacing all these unhealthy fats with healthy fats such as mono and polyunsaturated fats from vegetable oils, nuts, and fatty fish. So it is recommended to consume fatty fish such as salmon and mackerel for at least 2 times per week, or to consume 1 handful of nuts as snack daily. Tip number 5, practice a healthy diet by following healthy plate method. This can help you to control food portion well. So fill up half of your plate with vegetables, quarter of the plate with whole grains, and another quarter of the plate with lean meat or fish. And not to forget to complete your meal with 1 serving of fruits. So in summary, dietary control is very important in managing healthy body weight. But bear in mind, it should come hand in hand with regular exercise.
There are no drug treatments approved specifically for fatty liver disease. Treatment mainly aims at, firstly, controlling metabolic diseases such as diabetes and obesity by lowering blood sugar and cholesterol levels. Anti-diabetics and cholesterol-lowering drugs may be prescribed for this purpose. Secondly, treatment also aims at protecting the liver and preventing progression of disease by reducing oxidative damage and inflammation of the liver. For example, supplements such as silymarin extracted from milk thistle has shown antioxidant, anti-inflammatory, and antifibrogenic effects on the liver. However, it is important to only take medications and supplements only when necessary and as prescribed. So please consult your healthcare provider before any use of medications or supplements and ensure that you obtain a genuinely registered product.
In the care of patients with NASH, it's important to minimize or abstain from alcohol. Heavy alcohol consumption leads to progression of disease. No smoking, low caloric diet, regular exercises, and adequate physical activities are very important. Obesity assessment, weight loss interventional plan, and weight gain prevention is very important. Patients with NASH are encouraged to obtain their COVID-19, hepatitis A, hepatitis B vaccination. For those with chronic liver disease, influenza and pneumococcal vaccination must be considered provided there are no contraindications. In all patients with NAFLD, the risk factor for cardiovascular disease must be identified and modified. The control of metabolic parameters including weight, blood sugars, HbA1c, cholesterol, and triglycerides are vital. One needs to consider bariatric surgery for those patients who fail to lose weight with lifestyle modification in those who are morbidly obese. Patients with fatty liver need regular follow-up to monitor the progression of disease and the detection of complications. A follow-up every 3 to 6 months after the initiation of diet and lifestyle modification with exercise and activity, well, with or without medication, is vital. Weight reduction is a cornerstone of treatment of NAFLD. If you have any doubt about your care, please consult your healthcare provider or doctor.
So let's keep your liver healthy and disease-free.
Keep your liver healthy and disease-free.
Please keep your liver healthy and disease-free. Thank you.